Alright guys, so in this video we're going to be talking about wound healing a little more, but specifically we'll be talking about optimal wound healing. And as usual, the resources that I used for this video, of course, are Peterson's Principles of Oral and Maxillofacial Surgery, the First Aid for the USMLE Step 1, and OpenStack's Anatomy and Physiology, an open source book from Rice University. So, let's talk a little bit about trauma. So when we think about trauma, I'm not talking about trauma like accidents, but I'm actually talking about the trauma that we induce in the process of whatever we're doing. So the big things we're thinking about here are minimizing the size of the incision to create less tissue trauma during our procedure. Now in addition, we also need to think about how many sutures we're using, because while sutures may seem like, just a small little thing, and even they're helping us get primary closure, right? We need to also remember that the more sutures we have, the more we increase the number of surfaces for bacteria to adhere to. So there's kind of this middle ground of trying to find. It's almost like when we think about ALARA, which is the minimal amount of radiation we can give someone to get exactly what we need. We want to use the minimal amount of sutures we can to get exactly what we need. We want to make sure we achieve our goal, but we want to make sure we're not using too many, not placing unnecessary ones. So of course, the next piece of that would be hemostasis and debridement. So when we think about debridement, or I guess hemostasis first, we need to make sure we achieve hemostasis before closure. Now, hemostasis is important for two reasons. The first reason is because it increases the operator's view, it allows them to see more, but it also minimizes the risk of hematoma and infection. Now, there is a middle ground here as well, because blood and its nutrients are ideal for bacterial growth. So if you have too little hemostasis, you're going to increase the risk of infection and necrosis of the overlying flap. But if you have too much hemostasis, then you can reduce the blood supply to the healing area, thus prolonging the healing process. Now, another thing you can do, which is pretty important, of course, is minimizing dead space by inserting a drain or applying a pressure dressing. And I included a picture here of a pretty commonly used drain. So, the next piece is debridement. And debridement is the removing of foreign bodies and removing devitalized tissue. Now, both foreign bodies and necrotic tissue can be a nidus for bacteria, and they can reduce immune defense and encourage prolonged infection. Now, necrotic tissue, in addition to facilitating infection, it can actually stimulate an inflammatory response on its own, which, as we know, can create byproducts that an immature clot is unable to handle, right? We're thinking about reactive oxygen species. We're thinking about all the proteases that come with neutrophils and macrophages. So the immature wound, it's trying to heal. It actually can't even handle that. It has nothing to do with the infection at that point. It's even just the immune response that's damaging. Now, on another more macroscopic level, we have to remember that the necrotic tissue is a literal physical barrier as well, and it gets in the way of reepithelialization. So that's enough about debridement. Now, talking a little bit more about foreign grafts and implants, we need to also remember that foreign grafts and implants can elicit some degree of immune response themselves. So, since we just finished talking about hemostasis, it's important we now talk about, of course, perfusion. Now, perfusion is critical because oxygen itself is critical to a number of things. It's critical to collagen formation specifically, which is a huge piece of wound healing. And if we look at this picture again, it's critical to a few steps. It's critical right here to step number 2, which is the hydroxylation of proline and lysine residues, right? But it's also critical to step 6, which is right down here. And that's the polymerization and cross-linking of procollagen strands. Now, in addition, we need oxygen for so many more things, right? We need it for cell replication, thinking of endothelial cells and fibroblasts. We need it for optimal function of all cells, especially leukocytes, right? Because oxygen is actually a huge component of the immune response. And then it's, of course, necessary for angiogenesis, right? And we'll talk a little bit about a relative and a true hypoxia. Now, many wound closure complications, of course, we can relate them all back to systemic illnesses. And those illnesses can be traced back to, of course, perfusion and hypoxia. So what is the first one that comes to mind? What is the prototype of a systemic illness that causes perfusion issues and hypoxia? And if you weren't thinking about diabetes, you weren't thinking right, because diabetes, of course, is one of the biggest ones, right? Diabetes, we can have issues with peripheral vascular disease. It's essentially also a microvascular disease, right? But in addition to that, of course, we need to think about irradiation, osteoradionecrosis, infection, small vessel atherosclerosis, And the reason I talked about osteorative necrosis and irradiation just a little bit separately, of course, is because we need to think about irradiation of more than just the bone, right? Osteorative necrosis is huge in oral surgery, something to think about. When I say huge, it's something to think about, right? But irradiation as a whole, when we think about other tissues, we think about soft tissues, right? We have damage to the blood vessels there as well. That's why we get things like mucositis. So that's just another piece of the puzzle. So a little bit now about a relative versus a true hypoxia. Because in a previous video, we talked about how, you need a little bit of hypoxia so that angiogenesis is stimulated, right? Well, I thought, is it oxygen is good or oxygen is bad? What's the interplay there between neoangiogenesis and oxygen? Well, there's a difference between a relative hypoxia and a true hypoxia. Relative hypoxia is essentially the body understanding, I'm not getting as much oxygen as everyone else, so I need some more blood here. So it's going to promote neoangiogenesis or neovascularization, right? But a true hypoxia, that's actually just completely damaging. So relative hypoxia promotes healing, while very low levels of oxygen can actually cause damage and prevent healing. So let's look at how that works. So as we said, relative hypoxia promotes healing. True hypoxia, what we end up having is we have low oxygen and the resulting anaerobic metabolism that comes with it, right? Because if you have too little oxygen, the body says, I can't even perform these aerobic metabolism activities. I got to switch over to anaerobic. And all that is going to create an acidic environment. Now, toss on top of that the lactic acid, which is the byproduct of bacteria, suddenly you're going to have cell lysis and tissue breakdown. Now, the cell lysis results in the release of proteases, glycosidases, and those go on to just digest the extracellular matrix. And the big point here, the big takeaway point, is that a lot of deleterious things like hypoxia are double-pronged. So what do I mean by that? They don't just cause damage, they also prevent healing. So each one is a problem in itself, right? Causing damage is bad, right? But put that on the side, let's pretend it wasn't causing damage. Even if it was already damaged, now we've prevented healing. So it's two-pronged. So hypoxia, because of inadequate perfusion, can result in poor delivery of things needed for healing, like nutrients, antibodies, cells, and that protects the microorganisms from us, right? We don't have any protection from them because we can't get things to that site, right? So we're preventing healing. But in addition to that, we're actually causing damage with all this lactic acid, right? So everything you could possibly think of gets delayed. Neutrophil and macrophage migration. And if neutrophils don't migrate, you can't clear out bacteria via phagocytosis in the acute phase. But in addition to that, you have decreased presence of opsonins, IgG, C3b, C-reactive protein. And opsonins, of course, are crucial to optimal phagocytosis. So in that second prong of delayed healing, right, or I should say, preventing healing, not only do we have an issue getting the actual cells there, we have an issue getting those optimizers there, those opsonins, right? So that's how, we look at things like true hypoxia, and it doesn't just cause damage, it prevents healing. So more about perfusion, of course. What are some causes of wound and tissue ischemia? Some obvious ones, of course, are desiccation and tissue trauma, right? So that's pretty straightforward. The next one, of course, is poor perioperative care. And when we say poor perioperative care, what are we thinking about? We're thinking about bad suture placement, poor flap design, and those are kind of the two biggest ones. But now when we talk about systemic causes, we're thinking of things like hypovolemia, anemia, diabetes, the peripheral vascular diseases, those kinds of things where we're having issues getting all of our nutrients to the location of injury because of systemic issues. Now, of course, the next one is smoking, right? And smoking is huge. I mean, it is a beast in and of itself. The vasoconstriction from smoking is extremely long-lasting. Now, in addition to the vasoconstriction, we have issues with decreased collagen and prostacyclin, and we also have an increase in carboxyhemoglobin and increased coagulation and blood viscosity. So the best thing to do to optimize a patient who's smoking is we want to tell them to try to abstain for at least 1 week before and after the procedure. Now, of course, the effects of smoking on vasoconstriction are going to be way more than just, you can't just recover in 1 week. But that's the kind of our what we're trying to do. It's ideal, at least that, So another thing we can do is we can also propose hyperbaric oxygen, which is another way to increase perfusion. And we'll see this again when it comes to patients with a history of head and neck radiation. Okay? So a little bit about diabetes and peripheral vascular disease, so the systemic issues. Diabetes, when we think about the issues with diabetes, the biggest thing to remember is that hyperglycemia is the issue. Hyperglycemia is the issue with wound infection. It's not the diabetes. So what that means is that controlled diabetes does not place the patient at much of an increased risk. It's not the diabetes. It's not to be confused at all, because a well-controlled diabetic is not at a higher risk. It's the hyperglycemia. And the hyperglycemia for a number of reasons, right? So the hyperglycemia, of course, is causing issues with chemotaxis and phagocytosis, which is causing issues, as you can see as we move right on this chart, with neutrophils and lymphocytes. But in addition, we have an issue with poor permeability and circulation to small vessels in the wound. And that's an issue with oxygen and erythrocytes, right? So you have to remember that we're fighting two battles. We need to get oxygen there to at least tell the cells keep working aerobically, right? To at least promote an environment where we don't have a ton of acid and bacteria think they can flourish. But in addition to that, that's the erythrocyte delivery. Now we're talking about the lymphocyte delivery, or the leukocyte delivery, the neutrophils and the lymphocytes, right? That's just for the sake of healing. So the combination of a poor immune response and ischemia in these patients puts them at a huge risk for fungal and bacterial infections as a whole, right? So diabetics are a type of immunocompromised patient. That is what we consider them. Now, moving on to other types of immunocompromised patients, what we think about as a good marker for the immune status of a patient is their total lymphocyte count. And we say that anything less than 800 is going to be equal to total lymphocyte deficiency, a severe total lymphocyte deficiency. Now, of course, a mild deficit is somewhere between 1200 to 1800, right? But we also need to think about other things like patients with HIV, right? We're going to look at their CD4 count, and we'd say that they have a pretty poor wound prognosis if they have less than 50 cells per cubic millimeter, right? Now we have immunosuppressive therapy, but one thing to note is that there's no evidence of newer medications like cyclosporin affecting wound healing. But we do know that older medications alter the inflammatory reaction and cell metabolism. Now the last piece here is, of course, long-term steroid use, things like prednisone. So long-term steroid use is definitely going to cause an issue with the healing process. Now when we think about long-term steroid use, how does it come into play? Well, looking back at this picture again of collagen, and remember, collagen, we keep coming back to collagen because the synthesis of collagen is centric to the usage of collagen, and the usage of collagen is centric to wound healing. So long-term steroid use causes issues with the activity of lysyl and prolyl hydroxylase. So that right there is step 2. If you're looking at the piece that's kind of highlighted in red, it diminishes activity of lysyl and prolyl hydroxylase, it decreases fibroplasia, it decreased collagen deposition, and decreased neovascularity. And so what you end up getting, in addition to that, is delayed fibroblast migration. Now, what we find is that in these patients, wound strength can actually go down by as much as 30%. And in addition, we can have issues with reepithelialization and wound contraction. Now, if you think about that, the reepithelialization and wound contraction, I mean, that's just completely obvious, right? Because reepithelialization, well, we're going to obviously need collagen. Wound contraction, of course we need collagen, right? It's fibroblasts and myofibroblasts. So it's no shocker at all. Now, what we can do for these patients is we can give them vitamin A in an attempt to attenuate some of the inhibitory effects of glucocorticosteroids. So those are kind of the key points about long-term steroid use and immunocompromised patients and wound healing, or optimal healing. Now, the last piece we're going to talk about here, of course, is antineoplastic drugs, right? We're talking about things like methotrexate, allopurinol, 6-mercaptopurine, and of course they work by inhibiting the RNA and DNA production. And what's amazing is that a lot of these drugs, actually the history of these drugs is pretty incredible. It actually comes back to, they can all be traced back to the idea of, there was a scientist called Sidney Farber, and he was, if I remember correctly, he was a pathologist in Boston, and he came up with what he called anti-folate drugs. And his goal with these drugs was, well, first he thought, well, why don't I give kids folate? And I don't remember exactly why he thought folate was the move. So he tried giving them folate, and he realized he actually made cancer significantly worse. And so he realized, well, if folate's making it worse, let's try to create what we'll call anti-folate drugs. Okay? So he created things that looked like folate, but didn't actually activate or lead to the production of DNA and RNA. And that was one of the big birthplaces. That was Boston, of course, at the Children's Hospital. He was I think a pediatric pathologist. It's been a little bit since I read this book, but so he came up with some of the first anti-folate drugs, and that's what a lot of these drugs were based off of, or at least the premises of antineoplastics, the majority of them, or the majority of the ones that you really think about, methotrexate and those kinds of things, they are based on the idea of inhibiting RNA and DNA production. Now, who else needs RNA and DNA production other than bacteria or cancer cells? Well, normal cells, right? So the issue here is that we're having issues with our own normal cell replication, which of course is causing issues with the healing process. Now, other things to think about, of course, are there other types of antineoplastics, right? There's mycophenolate's another one, ribavirin, right? And that's an antiviral. So, it's amazing how we see a lot of these drugs used in more uses than just, this is an antineoplastic drug, but it's used in a lot of different things as well. So, the poor cell function that comes from this can manifest issues with fibroblast proliferation and collagen deposition. And it makes plenty of sense because we're having an issue creating these cells. Now, wound healing also gets delayed, of course, because when these drugs take their toll on neutrophils as well, they cause the inflammatory phases to get prolonged. Now, that pretty much wraps up everything I wanted to talk about when it comes to optimal healing. And I hope you enjoyed this video. I hope you enjoyed that last little piece about antineoplastic drugs. That actually is from a book called The Emperor of All Maladies, something I'm actually reading right now. I'm reading it in chunks. It's a really good book. I really recommend it. And so if you're interested in a little more of the history or the background for a lot of these things, that's a great book to go check out. All right, so thanks for coming to this, and I will see you guys in the next video.